Immunising a child not only protects that child, but other children as well, thereby providing population protection. It is vital that healthcare professionals take every available opportunity to immunise children, regardless of the reason for the visit. It is therefore important to check the child's immunisation history, preferably by assessing a written immunisation record, before deciding which vaccine to administer. Because rapid scientific and technological advances contribute to regular schedule changes, this video will not cover the current schedule. You will need to refer to the most recent edition of your immunisation handbook. This video will focus on the following key areas: pre-immunisation preparation, routes, needle gauge, length and angle, positioning and location of vaccination sites, administration techniques and documentation. Parents or caregivers and children need privacy and a comfortable, non-threatening environment when they come to the clinical practice. When working with children, be aware of their age and stage of development. Recognise that the parent or caregiver, as well as the child, may be very anxious. Where possible, avoid preparing the vaccine in front of the parent or an older child. Reassurance of children and their parents or caregivers can be achieved by effective communication, which can be reinforced by touch and tone of voice. Make sure that the parent or caregiver feels comfortable about holding the child for injections. Ensure the parent or caregiver understands what is expected of them and what will take place. Standard infection control procedures and occupational health and safety guidelines must be followed at all times to minimise the risk of harm to the vaccinator and others. Gloves are not required for vaccinators unless there is a risk of exposure to potentially infectious body fluids or the vaccinator has open lesions on their hands. Vaccinators need the appropriate facilities for the correct transport, storage, handling and disposal of vaccines and associated equipment. Be prepared to recognise and manage adverse events, including anaphylaxis. The vaccinator must also be prepared to use a translator or other communication assistance if it is required. It is important that an accurate and detailed history be taken to assess the child's reaction to previous vaccinations. The vaccinator should also assess for contraindications to the specific vaccines which are to be administered. The recommended procedures for obtaining valid consent from the parent or caregiver must be completed prior to immunisation. It is important to give the parent or caregiver take-home information about common reactions and what to do about them. The vaccinator should also inform the parent or caregiver about precautions following specific vaccinations, for example, OPV. A contact number should also be provided in case more severe reactions occur. All the injectable vaccines on the current recommended immunisation schedule can be administered by deep intramuscular injection. However, measles, mumps, rubella or MMR vaccine can also be administered by the subcutaneous route. Oral polio vaccine, or OPV, is always given by mouth. Palpate the muscle mass to assess muscle size in order to decide the depth of insertion of the needle. Most vaccines need to be deposited into the deep intramuscular region. Short needles increase the risk of inadvertent injection of vaccine into the subcutaneous layer. This is especially a risk for inactivated vaccines. In nearly all cases, the needle size should be 23 gauge and 25 millimetres in length. There are, of course, exceptions to this rule. For very small infants or preterm babies, 2 months or under, use either a 23 gauge needle, 25 millimetres in length, or a 26 gauge needle, 16 millimetres in length. For subcutaneous injections, use a 26 gauge needle, 16 millimetres in length. For subcutaneous injections of very small babies, a 27 gauge needle, 12 millimetres in length can be used. Needle length is more critical than the angle of insertion for subcutaneous injection. While the insertion angle of 45 degrees is recommended, the needle should never be longer than 16 millimetres or inadvertent intramuscular injection could result. For very obese adults, a 23 gauge needle, 38 millimetres in length, can be used for intramuscular injections. For intramuscular injection, the appropriate length needle should be inserted at an angle of 45 to 60 degrees into the vastus lateralis or deltoid muscle. Both neural and vascular damage has been documented from insertion of a needle at a 90-degree angle. Insertion of the needle at a 45 to 60-degree angle allows a vaccine to be deposited deeply. This reduces the risk of inadvertent subcutaneous vaccination and subsequent risk of severe local reactions. Correct angling of the needle may also reduce tissue resistance as the needle penetrates the muscle. Vastus lateralis. A needle of the correct gauge and length should be inserted just above the junction of the upper and middle thirds of the muscle. Insert the needle at a 45 to 60-degree angle towards the patella and posteriorly at a 45-degree angle to the tabletop if the child is supine. Deltoid. Correct location of the deltoid muscle is more important than needle angle for intramuscular injections. A correct length needle should be inserted at a 45 to 60-degree angle to the skin towards the acromion to ensure the vaccine is deposited deeply into the bulkiest part of the muscle. This also avoids inadvertent nerve penetration. It is important that infants do not move during the injection, so they must be adequately restrained. Excessive restraint can increase their fear, as well as muscle tautness and tension. Infants can be positioned by being placed on their back on a table or bed. The forearm is placed across the infant's pelvis and the thigh is secured between the vaccinator's thumb and fingers. This position minimises delay between injections and makes the injection process easier. Alternatively, the child or infant can be held by the parent or caregiver in the cuddle or semi-recumbent position on the parent's or caregiver's lap. It is essential to undo the baby's nappy when locating the anatomical landmarks for the vastus lateralis site. Otherwise, the vaccine may be given too low in the thigh. The injectable vaccines should be administered in a site that is as free as possible from the risk of local, neural, vascular and tissue injury. The vastus lateralis is a large, thick, well-developed muscle in infants, wrapping slightly onto the anterior thigh and extending posteriorly to the biceps femoris. Vaccine should be injected into the bulkiest part of the vastus lateralis. The vastus lateralis is the preferred site for vaccination of infants and children under 12 months of age. The following list describes the rationale for using the vastus lateralis. Avoids the risk of sciatic nerve damage in the gluteal region. The deltoid muscle is not sufficiently developed in infants to absorb medication adequately. Some vaccines, for example hepatitis B vaccine, are less immunogenic if injected into the gluteal region. Avoids the risk of local reactions and chronic injection site nodules associated with inadvertent injections into the neurovascular bundle, which lies immediately underneath the rectus femoris. Avoids the predominantly subcutaneous fat of the anterior thigh. To locate the vastus lateralis site, if using a bed or tabletop, have the infant on their back. Slightly adduct the leg with the knee flexed. On the lateral thigh, find the trochanter as the upper marker and the lateral femoral condyle as the lower marker. Section into thirds and run an imaginary line from the centre of the lower marker through to the centre of the upper marker. This line is highlighted for you because as you gently adduct the leg, the movement makes the fascia lata iliotibial tract dimple along its lower portion. The injection site or needle insertion point is on the midline just above the junction of the upper and middle thirds of the vastus lateralis. It is easier to safely position and restrain the toddler or preschooler for a deltoid injection if they are sitting sideways on the parent's or caregiver's lap. Alternatively, they can face their parent or caregiver while straddling their parent's legs. The arm to be injected is held close to the child's body, while the other arm is tucked behind the back of the parent or caregiver. It is essential to expose all of the upper arm when locating the deltoid site, to locate the anatomical landmarks. Otherwise, you may expose only the inferior portion of the deltoid, increasing the risk of nerve injury. In infants and young children, the radial nerve is very superficial in the middle third of the upper arm. An injection at the junction of the middle and upper thirds of the lateral aspect of the arm may damage the nerve. The rationale for using the deltoid muscle is based on its accessibility and good vaccine uptake for older children and adults. The deltoid is the site for intramuscular and subcutaneous injection of vaccines in children 12 months and older. To locate the deltoid site, locate the acromion process as the upper marker. Locate the deltoid tuberosity as the lower marker, in line with the axilla. Draw an imaginary triangle pointing downwards from the acromion. The injection site is in the centre of the triangle or the point halfway between the upper and lower markers. This will be from 1 to 4, possibly 5 finger widths, depending on the size of the arm. In children, the volume injected into the deltoid should not exceed 0.5 of a ml, and in adults it should not exceed 1 ml. Check the identity, batch number and expiry date of the vaccine to be administered, and check for obvious signs of deterioration. Any particulate matter or colour change may indicate damage to the vaccine. Vaccine should not be mixed in the same syringe unless a prescribing information sheet specifically states it is permitted, as there are no stability data studies available to support this practice. Different vaccines given on the same day should be injected into different sites. Draw up the correct vaccine using a non-touch technique and observe occupational health and safety precautions. Expel excess air from the syringe before changing needles, but do not push vaccine through to the outside of the tip of the new needle. Needles should be routinely changed after drawing up and prior to the injection of the vaccine. This reduces the risk of skin irritation and possible damage from a blunt needle. The vaccinator should now position themselves safely and, with the assistance of the parent or caregiver, position the infant or child. The appropriate site should now be located in preparation for vaccination. Recent studies show skin preparation with alcohol or cleansing may be unnecessary. Clean the skin only if needed. Alcohol swabs do not need to be used unless the site is obviously dirty. If using an alcohol swab, ensure the skin is dry before injecting the vaccine. Failure to do so may inactivate a live attenuated vaccine such as MMR, and alcohol may be tracked into the muscle with the needle causing local irritation and pain. Intramuscular injection technique, vastus lateralis. Immobilize the limb and hold the muscle correctly. Cup the knee in the palm of your hand, gently compressing the muscle with the index finger and thumb to immobilize the site. Insert the needle quickly and smoothly at the correct depth and angle towards the patella. Gently and briefly draw back on the syringe plunger. Slowly inject or trickle the vaccine into the muscle over a count of 5 seconds to allow the muscle to accommodate the vaccine. Fast injection of the vaccine may cause the fluid to be forced into a finite muscle space under high pressure, increasing the risk of injection pain. Forceful depression of the plunger may also cause the vaccine to backtrack along the needle shaft to the skin surface, which may cause superficial tissue irritation. If you are constantly getting a drop of vaccine at the skin surface following intramuscular injections, you may be injecting too forcibly. A large gauge needle allows a vaccine to be introduced under low pressure, especially if it is not administered too fast. Withdraw the needle quickly and release the muscle gently. Dispose of the needle and syringe immediately into the sharps container. If the site bleeds, do not apply an alcohol swab, but gently apply a clean cotton wool swab. Leave the site exposed to the air to ensure quick healing. Do not massage or rub the site afterwards, as massage may cause the vaccine to leak back along the needle track, leading to tissue irritation. Complete the recommended documentation. Infants or children should remain in the vicinity of the clinic or surgery for at least 15 minutes in case of anaphylaxis, which is an extremely rare event. Intramuscular injection technique, deltoid. Immobilise the limb and hold the muscle correctly. Cup the shoulder in the palm of your hand. Gently compress the deltoid muscle with the index finger and thumb to immobilise the site. Follow the procedure as demonstrated for injection into the vastus lateralis. Subcutaneous injection technique. A subcutaneous injection should be given into healthy tissue, which is away from bony prominences and free from large blood vessels or nerves. The deltoid area of the upper arm is usually recommended due to ease of accessibility and proven uptake. The lateral thigh is an alternative site. Immobilise the limb and locate the deltoid area of the upper arm. Select the correct gauge and needle length for subcutaneous injection. Insert the needle quickly and smoothly at the correct depth at a 45-degree angle to the skin and towards the acromion. Follow the procedure as demonstrated for injection into the vastus lateralis. Administration of OPV by mouth. The recommended dose of OPV is 2 drops by mouth for each scheduled dose. OPV is almost always given with other vaccines and should be administered before the injectable vaccines. It is important to avoid contamination of the dispensing cap when using a multi-dose vial, or if the vaccine is dispensed directly into the infant's mouth. Place 2 drops of OPV on a single-use plastic spoon and place the vaccine into the back of the mouth. An older child can use the spoon independently. With older children, explain that there will be a bitter taste. With infants, explain to the parent that the baby might make a funny facial expression for the same reason. Dispose of the plastic spoon into the sharps container. The dose of vaccine should be repeated if it is regurgitated within 10 minutes of administration. The vaccine providers and parents or caregivers should keep a record of what vaccines were given. In some states or territories, immunisation records are required before a child can enrol into childcare, kindergarten, preschool or school. The parent or caregiver or person being immunised must be given a record of immunisation, for example, in the personal health record book or a wallet card. The date, vaccine name, vaccine dose number, batch number and the site used should be included. Information about the next immunisation should also be supplied in writing. The record must be signed and, in some public clinics, stamped by the vaccinator. The vaccine provider must also keep records, which includes the vaccinee's name, address, date of birth, next of kin and phone number. This is an important legal requirement. The record should also include date, vaccine name, vaccine dose number, batch number, as well as the route and site used for the injectable vaccines, a note that valid consent was obtained, a date for the next immunisation, and the vaccinator's signature. Since January the 1st, 1996, providers have been requested to participate in the Australian Childhood Immunisation Register, which is operated by the Health Insurance Commission. A payment is paid to the vaccinator in return for data, which is sent to the ACIR. The ACIR is a system to enable parents to get reminder notices for future vaccinations and to allow vaccinators to check their patients' immunisation history prior to opportunistic immunisation. Data can be sent by manual forms or by electronic means. Contact your state or territory immunisation unit or the Health Insurance Commission for more information. Health professionals have a responsibility to administer vaccines in a safe and effective manner. We hope this video will assist you in the delivery of a high-quality immunisation service.